Thank you, Ryan. I'm really humbled by the invitation to speak to you this morning, and I'm inspired by the vision of this conference. I'm not a specialist. I'm someone who spent some time working in a variety of different aspects of queer health and public health, so perhaps I'm a bit biased, but I firmly believe the way forward is to create interdisciplinary networks, and I'm thrilled that this work is happening here in Ontario to more systematically link mental health providers and other service providers working with queer communities. Before I start my talk, and given that we're at a conference about mental health, I have to acknowledge I'm having a prime case of imposter syndrome here. So I recognize I am in no way an expert on the topic of mental and sexual health integration, but someone I trust recently explained to me that imposter syndrome is ubiquitous. So I'm going to attempt to move past my anxiety and share with you just a few stories, a few pieces of data that I hope will inform your work in some way over the next couple of days. My first job after university was as an outreach worker for a small gay men's health program in Oakland, California. This was funded by the state of California's investment in HIV prevention services. And I spent most of my 2-year stint there in the bathhouse for work. And I was ostensibly there to talk about HIV, just to be clear. But at that time and place in the Bay Area in 2002, men going to the baths had fairly good access to HIV testing. They had good access to condoms, to sexual health information. What they often didn't have was someone to talk to. And when I was working at Steamworks, I had the pleasure of meeting a man by the name of Peter Carnini, who at the time was a marriage and family therapist intern at the same queer community center where I worked. And at the bathhouse, he was known as Mr. Sex. He spent most of his clinical internship talking to men there on a drop-in basis. So I shifted my job to be his de facto receptionist, and I learned a lot about the desire for a talk-based intervention in a sexualized space like the bathhouse. Men were very often lonely or uncertain or shameful about their sexuality. Many of them just wanted to have better sex. Many also suffered from anxiety or depression. I know that Marco is here. I was chatting with Marco earlier. Marco developed a very similar intervention here in Toronto called Towel Talk. So we know from lots of different points that these types of interventions work and are really powerful. About 12 years later, I was still working in the HIV sector, but now in Canada, and I was volunteering at the Community-Based Research Centre for Gay Men's Health, or CBRC. And I just returned to my mental health roots by focusing my PhD on research to understand the epidemiology of suicide among gay and bisexual men. And at this time, a young queer man who was also volunteering at the CBRC died by suicide quite unexpectedly. And a group of us, including several of the people listed here, decided that this was the moment we needed to start to come together. And this group eventually became known as the LGBTQ Mental Health Roundtable. In particular, I want to acknowledge the leadership and vision of Aaron Purdy, who's here at the conference, right here. You'll be hearing from him later in the day, and Aaron has aggressively, yet thoughtfully, expanded access to mental health services for queer men in Vancouver, and this really inspires me. This afternoon, Aaron and I are going to be giving a separate workshop where we'll explain and explore kind of how we work together as researcher and practitioner. But the Roundtable, it's just a growing collective of individuals who work with queer communities, and we now meet quarterly. It's a creative and clever bunch who simply believe that if we continue to get together and share ideas, eventually we will forge a queer mental health strategy. We have no funding yet, in case any of you know someone who wants to help. We just believe, like I suspect many of you do, that the relative scarcity in mental health programs for queer communities is in part a problem with organizational and professional silos. And if we keep coming together and throwing out ideas, we'll naturally find ways to work together, and we already are. So both of these experiences, with Mr. Sex at the bathhouse, with the Mental Health Roundtable, taught me not only about the scarcity of mental health supports available to our communities, but also about the potential to leverage the infrastructure our communities have built over the last few decades around HIV care and prevention. And that's what I want to talk about today. I'm going to share with you the story of how my research has cycled back around to trying to understand the intersection of sexual and mental health within sexual minorities, and to understand where public health can intervene most effectively and most efficiently. Okay, I'm an epidemiologist. I really like statistics, but a few people told me to try to tone them down for this talk, so I've done my best. This is one I must share, though, over and over again, and if you've heard me speak before, you're probably tired of hearing about this. These are data from my PhD research, which included a systematic review of suicide-related outcomes among adult gay and bisexual men. And I want to take a moment to thank and acknowledge, there's lots of acknowledgements in my talk. part of my imposter syndrome. I want to acknowledge, in particular, one of my mentors and PhD supervisors who's here, David Brennan. Thank you, David. David really has been so integral to my exploration of this topic. And when we did our systematic review, we found really a striking disparity in suicide-related outcomes like ideation and attempts that persists today, whereby sexual minorities are about 4 times more likely to have attempted suicide than heterosexual counterparts. So that means 1 in 5 of us has tried to end our lives. We similarly have robust evidence to demonstrate persistent, albeit smaller, disparities in depression, anxiety, and problematic substance use, as you can see here, all of which are 2 to 3 times more prevalent in sexual minorities. Together, the excess burden of mental health struggles borne by queer people that is above and beyond what we would expect based on heterosexual counterparts, whether we're measuring this by deaths or doctor visits or daily struggles, is enormous. I want to explain that I'm using the term sexual minority because we see these disparities across the lesbian, gay, bisexual, queer, and two-spirit umbrella, irrespective of gender. And in fact, in many of the cases, these disparities are even larger for sexual minority women and trans people, which is something I'm going to talk about later. The disparities are even larger among indigenous sexual minorities and two-spirit people, and even larger among people living with HIV. So we have a complex task. Why is it so important for me to repeat these statistics? I'm sure they're not a surprise to many of you, given that you're working in mental health. But when I share my research with policymakers and researchers who are not working in queer contexts, they are struck by these statistics. They'll say something like, well, this must be an artifact of the past, pre-marriage equality, pre-combination HIV therapy. It's not. It's something that continues to affect us today. And so we need these statistics to remind and motivate public health administrators that these issues deserve our attention. The problem, at least that I want to discuss today, is one of access. I'm going to start my talk by outlining some of the issues that I think we need to tackle with regard to mental health care access for sexual minorities, and then I'm going to give you just one solution. This will be one of many proposed solutions over the next 2 days, I'm sure, but I'm going to try to convince you that this solution, STI clinics, is a particularly effective place to reach sexual minorities affected by these issues. These are data from Sex Now. For those of you who don't know, Sex Now is a serial survey. It has traditionally included about 8,000 Canadian gay and bisexual men. It's administered by the Community-Based Research Centre for Gay Men's Health in Vancouver. And it's been online the last 10 years. The last cycle in 2015, we found that 20% of the men we surveyed had reported suicide ideation or attempts in the last 12 months. Now, we also asked, who did you talk to? Did you disclose any mental health concern to any provider? By any mental health concern, I mean not only suicide, but also depression and substance use concerns, which we know can often precede suicide ideation. And by any provider, a family doctor, mental health provider, anyone in a professional setting, and fewer than half did. In psychiatric epidemiology, we call this the treatment gap, and it is unacceptably large. I'm sure it's what motivates a lot of you to be here. Now, we might disagree about what intervention should be offered to these men, but I think we would all agree that this group minimally should have a discussion with the provider to know what options are available. So I'm working with a group of researchers and providers, including several of the folks listed on the slide earlier, to start to pick apart, well, what are some of these barriers that keep sexual minorities from getting to mental health support? These are data from a different survey. This is the National Online Still Here survey that just wrapped up a couple of months ago. It's led by my collaborator, Olivier Ferlat, who's with the School of Nursing at UBC. And we sampled just over 2,500 gender-diverse sexual minorities from across Canada. We asked them about lots of aspects of mental health, what conditions are they currently experiencing. We asked about mental health literacy, and we asked about barriers to accessing care. So here I'm showing you their self-reported barriers to accessing professional mental health services, specifically among those who scored positive on depression or suicide scales. The first 2 things that you see here relate to cost and insurance, which is totally consistent with the literature from heterosexual and cisgender populations. But I want to point out there are reasons to believe that these barriers might be experienced differently by gender and sexual minority populations, either due to limited work opportunities, perhaps due to discrimination or fear of discrimination, due to limited access to extended health insurance or income through long-term partnerships, which are less prevalent in sexual minorities, or poverty, which is, of course, very closely related to the 2 things I just mentioned. The next 2 barriers speak to issues of stigma and cultural beliefs about mental health, wanting to solve the problem on my own, or often we hear things like, well, I'm going to wait it out. or dislike of talking about my feelings, emotions, or thoughts. For those of you who are able, I encourage you to join us tomorrow night at Buddies in Bad Times, where we'll be showing photography from the Still Here Photo Voice project. This was the qualitative arm of this same study, and the goal of that project is to share the stories and images of queer and trans people affected by suicide. They've interviewed, I think, over 50 so far. But also the goal of that project is to open a dialogue within our community and thereby to reduce stigma. And I've been to a few of these exhibits now, and I can tell you it definitely inspires people to talk about some issues that are otherwise hidden from our conversations. Okay, so then the next two barriers, these are even more particular to gender and sexual minorities. 1/3 of the people we surveyed who were struggling with depression or suicide were unable to find an LGBTQ2S or LGBTQ2S friendly professional. So this, of course, speaks to the importance of the work you are all doing, but we need to figure out ways to scale it. And the last barrier, on the face, the concern that I might be seen as weak for having a mental health problem doesn't appear to be related to sexuality, but to me it really is, and this is why. This is a quote from one of the gay men I interviewed as part of my doctorate. These were gay men who had attempted suicide, and then they sat down and told me their stories about suicide in their own words. And he said it was a balancing act, trying to fit in with family and friends circles. It was trying to fit in with the general public, how they perceived me. And one of the things, ever since I can remember as a kid, was always trying to please other people to compensate the secret. He's talking about the secret about his sexuality. This tendency kept him from seeking help for his suicide ideation for years. He had added pressure because his parents were from outside of Canada and from a culture that emphasized the importance of emotional strength. He didn't want to be viewed as weak, so he didn't tell his family about his suicide attempts for decades. But this isn't unique to this man or even his cultural background. It came up over and over again in my interviews. It's not even unique to my study. 2 years ago, at the Gay Men's Health Summit in Vancouver, we had the pleasure of hosting John Pachankis from Yale University, where he shared the results from a study testing what he calls the best little boy in the world hypothesis. The idea is that gay men and other sexual minorities will try to compensate for the secret of being gay by over-investing in other domains like academics or appearance or competitive extracurricular activities. As a former debater and tennis player, marching band member, glee club member, math tournament participant, I can attest to the relevance of this theory. What does it have to do with mental health? Well, apart from the toll it exacts on our emotional well-being, which it does, it means that we do a lot of work keeping other potentially damaging information from getting out, and these include things like depression and suicide and drug use. I think Boy George said it first, but I've heard others say it as well. We're like social chameleons. And what about when it comes to healthcare interactions? What does it mean? Well, this study was done in the States many years ago, but I've seen other similar studies since. What they did is they surveyed a number of sexual minority adults who, by the way, were already connected to healthcare. But they found that more of them avoided mentioning their sexuality to a healthcare provider than disclosed it. In fact, it seemed to be easier for these respondents to disclose to their parents, often reported as the most stressful event in the coming out process, than to healthcare providers. Now, concealment of sexuality is not equal to concealment of mental health struggles, but they are highly correlated. I want to lastly point out, before I move on to my next of my many preamble points, that there are important social and geographic gradients in sexuality disclosure to healthcare providers. These are data from BC, also from the Sex Now survey. We looked at the percentage of gay and bisexual men who are out to at least one healthcare provider about their sexuality. And you can see here in green on the left, in Vancouver we're not doing too bad. About 75% are out to at least one. But as soon as we step outside the city limits, it goes down to 50%. Okay, so hopefully I've convinced you we need to get creative in how we connect sexual minorities to mental health supports. Now I'm going to make the case for STI clinics. I'm going to attempt to answer 4 questions. 1, why STI clinics? 2, okay, fine, STI clinics are a good place, but what is the level of service need? 3, what are clients' desire for mental health services at the STI clinics? And 4, how do we do it? Okay, what kind of setting are we talking about? These are surely very distinct settings. This varies from jurisdiction to jurisdiction, so it might look a bit different in Ontario, but in most parts of Canada, when we talk about publicly funded STI clinics, they have a mandate specifically related to HIV and STIs, so the administrators are funding them on the basis of HIV and STI testing and diagnosis, and I'm doing interviews now with STI clinic providers, and I can tell you the providers understand that that is what they are being paid for. But they have a few characteristics that are important for our purposes. First of all, they don't require a primary care referral. Second, they're low barrier, either with regard to cost. In BC, most publicly funded STI clinics are free of cost to the user, and you don't have to show any kind of identification. This is helpful for immigrants, this is helpful for youth, this is helpful for people who are feeling stigmatized, for trans people. And lastly, many of these clinics are affirming spaces for gender and sexual minorities, at least relative to other ambulatory settings. I want to acknowledge all clinics have more work to do around being more inclusive, but I think we have a good place to start here. Okay, so that's all well and good, but why mental health integration in these settings? Well, the first reason is largely theoretical, but increasingly empirical and practical. Syndemic theory was articulated first by medical anthropologist Meryl Singer in the 1990s and extended to study gay and bisexual men by Ron Stahl about 10 years later. And it posits that the co-occurrence of conditions like HIV, STI, mental health concerns, and problematic substance use in particular populations, including gay and bisexual men, is explained in part by social conditions, things that I heard Dane reference earlier, sexual stigma, exclusion, marginalization. But also that these conditions are mutually reinforcing, which means when it comes to HIV, successful and holistic prevention requires also addressing these syndemic pathways, if you will. But of course, those of us working in public health and gay men's health should be concerned with other outcomes besides HIV, right? So these same social and psychological factors are repeatedly found associated with things like suicide and care and treatment for HIV. Syndemic frameworks ask us to measure and evaluate our interventions with regard to multiple outcomes. So this sounds really straightforward, but I can tell you from a health systems and a public health perspective, this is radical. I know that many of you here are well versed in this subject matter, are in fact leaders in this area of research, so I want to acknowledge the work of Barry Adam and Trevor Hart, who are here and are presenting on their work. I know they've done a lot of work in this area. Daryl Tan at St. Mike's has also looked at this in relation to people accessing PrEP and other HIV prevention options. So there's some really promising work happening in this area at the intersections of syndemics that I think makes an STI clinic not too far a stretch. The second reason, again, is data from the Sex Now, but that same subset of participants I showed you earlier who were currently or recently struggling with suicide. Now remember, over half of them hadn't talked to a mental health care, had not talked about their mental health concerns with any provider. And so I wanted to understand, well, where did they show up in our healthcare system? And where did they show up in our community? So that if we were to get a little bit better, a little bit more attuned to suicide ideation and other mental health issues, where could we find them? Well, 59% of them have a family doctor. They just didn't talk to them about their mental health concerns. 29% went to a walk-in clinic. 13% saw a mental health provider, but likely this was before the onset of their suicide ideation. 50%, this is the most important for the purposes of my talk, 50% of them got an HIV test in the last year, and 44% were interested in PrEP. This was a year before it was even approved by Health Canada. Another 16% volunteered in one of our gay health organizations. There was no single setting where we could reach these men, but 88% visited at least one of these venues. So it takes a network. I want to point out that this network of healthcare access looks different for sexual minorities than for heterosexuals. There continue to be reasons why sexual minorities will avoid some healthcare encounters, just like I showed you on the slide earlier. And for these reasons, I believe sexual health clinics are an opportune and efficient place to reach them. And the final reason I'm pointing your attention to the STI clinic has to do with the theme of interdisciplinary, multidisciplinary care. Some of you will be familiar with the work of Daniel Martin, who has courageously and ambitiously outlined a major reform to the Canadian healthcare system in order to reduce inequities in healthcare access and to integrate primary care. And one of her arguments is that Canada's over-reliance on fee-for-service models of physician-led primary care has stymied the opportunities to grow creative interprofessional models of care. In BC, primary care settings have very low involvement of nurses, hardly any, while STI clinics, on the other hand, are remarkably flexible in comparison. In fact, most publicly funded HIV tests in BC are delivered by nurses. So I think there's an opportunity here in coming up with more flexible models that are meeting the needs of sexual minorities and that are meeting them in a way that I think is more holistic and more affirming of who they are. Okay, so next, I want to look at the level of mental health service need among these clients. When I started my postdoc, I was reasonably sure we would find an elevated level of mental health issues in STI clinics based on syndemic theory, but there wasn't much evidence for it. And so it's important to have these numbers when we go to administrators of clinics to make the case for them that, in fact, some of these mental health conditions, most of them, are more prevalent than their STI diagnoses. So I launched a survey at 6 publicly funded STI clinics in Greater Vancouver. These include 4 clinics operated by HIM, a gay men's health organization, and big thanks to Aaron for getting this survey off the ground. It also included 1 public health clinic in the gay village that has historically responded to HIV among gay men, but now sees clients of diverse gender and sexual identities. About 80% of their clients are sexual minorities. And 1 high-volume public health clinic, which predominantly serves heterosexuals, but by volume actually serves more sexual minorities than the other clinics. About 1/3 of their clients are sexual minorities. We sampled about 1,100 clients. 65% of them were sexual minorities. Not surprisingly, we found very high rates of self-perceived mental health needs. Now, we asked this question a little bit differently than you'll see in most research. We asked, we defined each of the mental health conditions, and then we said, have you experienced this in the last 12 months and wanted to talk to a mental health care provider about it? In other words, we wanted to demonstrate the level of service need, because we know that a lot of folks who are struggling, let's say, with depression or anxiety, aren't yet in a place where they want to open up about it. So we found that depression and anxiety were by far the most prevalent. Over 1/4 of clients reported each of these. But substance use and suicide were also fairly prevalent. And most important, the piece I want you to take away from this is that 72% of those clients who reported an existing mental health need had not yet talked to a provider about it. We interpret this as a critical opportunity to reach individuals who are at need and otherwise wouldn't receive attention. Now, because these were not standardized measures, we also included 1 standardized question that appears on the Canadian Community Health Survey, lots of other international studies. This is about self-rated mental health, which is surprisingly predictive of relatively common mental health conditions, so things like depression and anxiety. And by this measure, 14% of our STI clinic clients had fair or poor mental health, which is twice the age-adjusted provincial average in BC. So again, together we think we have really an opportune, targeted setting for addressing mental health. Then we invited clients on the back side of this questionnaire to write in about their experiences with mental health. And this was some of the most fascinating data we got out of this study. We found that first, that some of the barriers that they were facing related to limited timing when it comes to primary care visits. So this first client says, well, I have anxiety and PTSD, which makes it very hard for me to access good medical care. First, since good medical care is such a trigger for me, but then they also say a 5-minute visit is not productive. It rarely gets me the total care I need. Of course, there are patient visit pressures at the STI clinic, but because these sites are often nurse-led, and because they don't operate on a fee-for-service basis, they tend to have more flexibility. And this is what the nurses have been telling me. When they have a client who kind of meets this profile, they'll spend more time with them, and they're able to. The second theme that emerged was really about comfort. It's about finding the right setting and time to open it up. And for all of you who have yourselves dealt with mental health issues, you know it's not something that is easily diagnosed. It's not easily acknowledged. So this client said it was hard for me to connect with needing mental health services. It took a lot of time, a lot of conversation with people close to me before I connected, and then money was an obstacle. Again, the familiar issue of cost. We can't eliminate this issue in the STI clinics, of course, but we can control it. In Vancouver at the BC CDC, and with help with the CBRC, we're currently working on a mental health service map that's going to be available to STI clinic nurses and eventually the clients that will better identify low-cost or sliding scale options that are queer and trans affirming. And this is informed in part by some work from Ontario, from Roberto Ortiz and his team at Max Ottawa. Okay, so not terribly surprising, we have a high level of mental health need in the STI clinics, but what administrators, including my supervisor, immediately wanted to know was, okay, so far, nothing shocking, but do clients actually want to receive mental health services at the STI clinic? Does this make sense? So we asked a couple of questions to address this. First, we wanted to know, what is your relative comfort in talking about mental health concerns with 4 different audiences? STI clinicians, a family doctor, your friends, and your family. And we found that 88% said they were comfortable talking to a sexual health provider. By comparison, 80% were comfortable talking to a family doctor, right down to 58% when it came to family. We also asked about interest in receiving mental health services if they were offered on site. So specifically, we wanted to know about assessments, referrals, and counseling on site. About 85% were interested in each of these. Now, take these results with a grain of salt. I don't interpret this as meaning that 85% of clients are suddenly going to enroll in these services, but rather this helps when I talk to people like my boss to explain, okay, the vast majority of clients are not opposed to it. They don't think this is some far-flung idea. And the qualitative comments with regard to appropriateness of the clinic for mental health integration were really in support of this conclusion. Someone said, I find this clinic is a better avenue for these types of issues as opposed to my family doctor. The nurses and staff at this STI clinic are well-informed and warm people. I think this is a great setting to offer these services since people may be more open since they are here for other taboo reasons. There were a couple who expressed a concern that if we add more services, if we add in mental health services, will this make the wait times even longer? People are frustrated with how long they have to wait to get STI and HIV screening. But as Dr. Martin argued, truly integrated care, our long-term vision, looking decades in the future, will ultimately decrease wait times by ensuring that clients are receiving the care they need. I've had so many conversations with STI nurses who spend time offering HIV and STI testing to clients who are at low or no risk. And they do this because that's the tool that's available to them. But in fact, if they did a more thorough assessment, they might argue to me that these clients are suffering from issues like anxiety or sexual shame. The other important question here is, well, what do the providers think, especially when we think of the issue of time pressures? So to answer this, I've started a qualitative study. So far, we've interviewed 10 STI clinic providers, so it's too early, unfortunately, for me to share with you these results. But in the next few months, we'll talk to 30 in total. The idea is just to understand, we know they're doing this work already, so how do they make it work within the constraints of a funding model that asks them to deliver HIV tests? But also to say, well, what would the future look like? And most people are pointing to things like integrated care. So how will that work in your setting? Who do we need to have at the table? What information do we need to have? One of the nurses, the first thing that struck me from the first 10 interviews was that really both sides, both the client and the nurse, see this as a really great perceived opportunity for syndemic service integration. Not everyone, I asked them, well, do you know about a syndemic? And most of them do not know the term syndemic. But when I explain it to them, immediately this has relevance to the work that they're doing. This nurse said, I try to make people as comfortable as possible. I think because it's an intimate setting, because it is around sex and around genitals, I think maybe people just have this extra openness. It's the exact flip side of what the client is saying. There's something about this space where we say we're here to talk about sex brings down one extra barrier, just one of those barriers that's on the slide I showed you earlier. So how do we do it? First I want to say, as I said a moment ago, STI clinic providers are already doing this work. It's just not counted as such. We don't have systems to track it in the same way that we do with biomedical outcomes. So what I hope we can do is find ways to acknowledge and support and expand this work. And for me, this is the hardest question. I think my best guess would be that as researchers and administrators and mental health practitioners, we need to present the STI clinics with options that make sense in their context, which is not going to look the same as it might in private practice or in a hospital or in another clinic. This is something I learned from Peter doing the Mr. Sex intervention back in Berkeley. He adapted his practice in so many ways that made sense in the context of the bathhouse. So it requires a lot of flexibility. I imagine, Marco, you had to do many of the same things with Towel Talk. I don't have a silver bullet to offer here, but these are 3 general models I can foresee based on the interviews I've done and based on other people I've talked to. The first is screening for all STI clinic clients for relatively common mental health concerns, things like depression and substance use. Those who score positive are offered referrals. That's it in a nutshell. And this is something that has been relatively successful in the UK and in the Netherlands. And in fact, a colleague I met just this last summer, Roel Achterberg, has recently launched a randomized trial to evaluate the effectiveness of routine screening versus the regular nurse assessments to get people referred to mental health services. So in a few months, we'll know how that's working. The second model is co-location of mental health providers. This is the current approach of the Health Initiative for Men Clinic in Vancouver. They have mental health support navigators and counselors on site and available for referral, often in the same clinic where they're receiving their STI tests. And the third model is team integration. This means, and this is what Daniel Martin envisions for all of primary care, all I'm telling you is I think we have to adapt it outside of a family doctor setting if we want to effectively reach sexual minorities. This means that mental health and sexual health staff are employed by the same organization, the same bucket of money, They have the same bosses, they are accountable to the same people, and they're under the same institutional system. And in Boston, this is what happens at the Fenway Health Center. It's a gleaming example of this. But Boston started, much like we are, with a various collective of clinics, some of which are HIV-focused. And over time, they integrated their systems so that now your visit at Fenway begins with a holistic health assessment that could lead you to see a number of different providers based on your needs. And as I mentioned before, in interviewing the nurses about what they see for the future, almost everyone talks about integration. This is the dream. So the question is, how do we get there next? This is a conceptual diagram that I've drawn for how syndemic care at the STI clinic likely looks. I want to acknowledge, this isn't like future looking. This is in fact what I think is probably happening now, although much of this remains unmeasured. So from a population perspective, we know that there are subpopulations of service focus. This is usually based on equity, who's been missing out historically from receiving services. And these include social groups who have experienced disproportionately higher rates of migration, stigma and discrimination, and/or trauma. And you can see this includes not only sexual minorities and gender minorities, but also indigenous peoples, immigrants, among others. These fundamental conditions are simultaneously giving rise to a higher burden of mental health-related concerns, perhaps also sexual health concerns, but also they're limiting their access to effective mental health care. Why? Because of experiences of trauma, because of experiences of stigma, discrimination. They might be avoiding certain encounters that they perceive as re-triggering or reinforcing those types of trauma and prejudice. So there's a phenomenal opportunity here when they show up at places like the STI clinic and other publicly funded low barrier and non-judgmental points of care. So what I hope is by shining a light on these factors and by shining a light on how people are showing up at the STI clinic and why we can accelerate access for populations who continue to face multiple inequities in health, including the ones you serve. The last point I want to leave you with also relates to equity and allyship. These are data from a systematic review I've just published with Laurie Ross's team here at University of Toronto. We looked at rates of suicide-related outcomes across multiple sexual identities. Again, we found that the rate of suicide ideation and attempts among gay men is unacceptably high and significantly higher than in heterosexual men. However, the gradients keep going when we look across the sexual minority population, when we look across genders and specific identities, so that the lifetime rate of suicide attempts among lesbian women is even higher than that of gay and bisexual men. And bisexual women experience the highest rates of suicide attempts of all sexual minority subgroups. And lastly, we know from TransPulse here in Ontario and other comparable surveys in the US that trans people experience rates of suicide attempt that are even higher still. So on this basis, I want to challenge us as we think about solutions to addressing mental health access for gay men to also find ways to extend these innovations to support our queer and trans allies. And I want to thank you for your time. I want to thank my supervisors, Mark and Jeannie, and my friend and collaborator, Olivier, and my project funders listed here. And if there's time, I'm happy to answer any questions. Thank you.